Thank you. Good morning, Professor Chili, Chairman, Co-Chairman, ladies and gentlemen. My talk will be about IOC consensus statement on pain and management in elite athletes. At the beginning, for setting up this meeting, actually I would like to set up FIFA consensus, something like that. But after I reviewed some consensus statement, after Professor Chili left FIFA from 2016, less consensus work from FIFA side, so we have to set up like IOC consensus in several aspects. So I start with the first slide. The talk today is I review from this work IOC consensus meeting 2016 in Berlin. After that year, they published good paper in British Journal of Sport Medicine 2007 regarding to this aspect. You can see Professor Chili names in as co-author of these articles. The pain is very common in sports injury and it affects to the performance of the athlete. And a lot of the variety modality to treat the pain. This is the Olympic 2016 team physicians surveys. This is non-medication treatment for pain. The top rank is physical therapy. The second is massage. And for the medication treatment for the pain in the same event, the NSAID is the most common medication, followed with the paracetamol. The outline from this article, they talk various things about the pain. They talk about the mechanism of the pain, they talk about principle and medical treatment, non-medical treatment, and also doping issue. But because I have short period of time, just 10 minutes, so I just would like to focus on the medical treatment and non-medical treatment only. For conclusion, for your practice in the future. Actually, we quite familiar to using the NSAID, so pretty easy to understand this principle. So the core principles of making the diagnosis of the patient. The first one, injury may occur without the pain, and pain may present without evidence of injury. So the pain management and injury management are not necessarily the same identical. So I start with the medical treatment for the pain. The principal guideline, actually it looks simple, but I highlight in the yellow letter on the important thing. The first one, the medication should be not the only one of the component. You should use the medication treatment and non-medication combination together for pain management. The second one, the medication should be lowest effective dose and shortest period of using. The third one, because we work with the athlete covered by the rules and regulations. So physicians should understanding rules and regulations regarding to prohibited substance. We have to know what cannot use, what can use for the athlete. IOC divide the medication management based on pain severity and anticipation return to pain. So physician has to categorize the level of the pain and has to just if the athlete can go back to pay or not. This is by clinical judgment. So they divide how to manage the pain by medication to be 5 groups, but actually 4 groups. The first group, the athlete come with acute pain, same day injury. The second and the third group, patient come with injury in the past, not the same day injury, but different severity. The fourth group is subacute and chronic pain. So I go to the first one. Again, the first one, athlete come with acute pain same day of the injury. You assess them in the field or in the locker room, something like that. So if you adjust them and you evaluate them and think that they can do same day return to pay, the athlete has mild or moderate pain, the medication go to follow this table. So it's simple to remember because it's a common medication that we keep using all the time. Paracetamol, NSAIDs, both traditional and COX-2 inhibitors and local analgesic. But you can see the doses. The loading dose up to 2 grams is quite a lot. And the maximum dose per day is 1 gram per day. And you see the maximum dose of each medication, ibuprofen up to 800 milligrams, naproxen 500 milligrams, ketorolac, celecoxib, even 400 milligrams 2 times a day, and etoricoxib 120 per day. If athlete has moderate to severe pain, you can give them NSAID injection like ketorolac or local anesthetic agent, but not intralesion. If there is going on hematoma and athlete would like to, athlete can return to pay at the same day, you should avoid traditional NSAIDs because it can make the hematoma become bigger. No role of the opioids on same-day RTP. Avoid intra-articular injection, especially on the weight-bearing joint. Avoid intertendinous, interligamentous injection with the local anesthesia if they would like to return to same-day RTP. No role of cortisone, of course. Cortisone, PRP, viscose supplement injection for athletes to want to do same-day RTP. This is the evidence. But if you just the patient, just the athlete, they cannot go back to do same-day RTP, like fracture, major fracture, you cannot go back to play for sure. You can add more choices like intravenous morphine, fentanyl, or inhalation of some gas like nitrous oxide, or intranasal morphine. But in Thailand, I don't think there is this kind of medication for nasal spray or inhalation not available in the market. The second group, athletes see us beyond the day of injury, not the same day of injury, beyond the day of injury, but the severity of the pain is mild to moderate acute pain. The medication is the same as same-day injury with paracetamol, NSAIDs, and topical analgesic agent, but you can add cortisone injections without doing TUE, therapeutic use exempt. If you do intra-articular injection, bursal injection, peritendinitis, epidural, facet joint, and SI joint, you can do that without using TUE. But you cannot do cortisone injection intramuscular and intravenous. You cannot do that. For more severe pain, you can use opioid. Opioid is like controversy right now because opioid has some side effect in sport, right? Patient can be, athlete can be dorsy, can be harmful to the audience, to the crowd, like in racing, in biking, in cycling, or in basketball. It's very close to the crowd. It's not just dangerous to the athlete itself. So opioid is controversy. So if you have to use opioid, you have to do TUE. You have to ask for permission. But anyway, opioids are the most effective medication for severe acute pain. Not just the pain relief, it can facilitate early mobilization as well. So opioid has room to use, but you have to use with the caution. But caution is not that difficult. You just make sure of the diagnosis. You have to set the goal of the pain reduction level. You have to re-evaluate the patient, and should it be the first line of the medication, you should use it combined with another medication, and should use it lower dose as possible. And the important thing is you shouldn't use beyond 10 days. If you have to use the opioid more than 10 days, you have to look back your diagnosis, your treatment in the past, is something wrong. If If it's more than 10 days, you have to do that. So IOC doesn't recommend to use opioid more than 10 days. The last group will be subacute and chronic pain. You can add anticonvulsant like gabapentin, pregabalin, gabapentin, or antidepressant like duloxetine, or tricyclic antidepressant like amitriptyline without doing TUE exemption. The last group, the cannabinoids or cannabis, is rising star of the pain management, but because it's safer than opioid, but the current evidence does not justify to use the cannabinoids or any kind of cannabis for pain management in the elite athletes. So don't use the cannabinoid or cannabis yet. Cannabinoid. So the last group is actually a big group as well, but I think the time is running out. So non-medical treatments for the pain. You can see that the highlight, the yellow highlight is the thing that IOC say that has evidence for reducing the pain, which is exercise, for movement exercise, strengthening exercise, conditioning exercise, psychological treatment, sleeping treatment, because sleep and pain is reciprocal thing. When you have pain, you sleep less. When you sleep less, the pain threshold going to be lower. So you have to take care about the sleeping as well, and surgery for some indication. The surprise thing is physical modalities and massage. They say that there is little evidence for proving that physical modality and massage has benefit for relieve the pain and not substance, except low energy laser therapy for tendinopathy has role for reducing the pain. So this is just a little bit surprise to me that physical modality and massage, not much evidence to prove to reduce the pain. Okay, so last slide, conclusion for the pain medication. If athletes got same day injury and same day RTP, you can use paracetamol, NSAIDs, and topical. Same day injury, severe pain, no RTP, you can add intravenous inhalation, intranasal opioids. And it's at least see you beyond the day of injury, you can add cortisone injection, opioid. And subacute and chronic, you can use anticonvulsant, antidepressant. And thank you again for a very lovely dinner yesterday with Professor Chidi and the family and the friends. Okay, this is, you can download the slide if you take this QR code. Thank you very much. If you like to have to ask some question, I think we have master here, which is Professor Chidi here. You can ask everything. Okay, thank you.
Thank you.